morning everyone, my name is Inesh and for my oral case presentation today I am presenting a case of Adenosquamous carcinoma of the gallbladder, a rare entity where it has both the components of squamous and adenocarcinoma. So between glands and squames, navigating the diagnostic maze of gallbladder adenocarcinoma. Here's presenting a case, but before that, gallbladder cancers are the most common biliary tract carcinomas affecting females aging 43 to 89 years with a mean age of 66.6 years. Females, obesity, gallbladder polyps, infections with Helicobacter, Salmonella, and pancreaticobiliary duct anomalies are common epidemiological risk factors. Now, gallbladder carcinomas, the most common ones are adenocarcinomas, but adenosquamous and pure squamous cell carcinomas are the rare ones. Adenosquamous carcinoma being defined as having greater than 25% squamous component in the tumor, and it constitutes 2 to 10% of all gallbladder malignancies. So it is even more rare. It is rare, but it is highly aggressive owing to the squamous component, causing a large size, local invasion, and early lymphovascular and perineural spread. It has a poor prognosis and less than 10% 5-year survival rate. Early stages are asymptomatic, leading to late diagnosis and advanced stage. And a treatment overview about which I'll come later. Radical surgery with adjuvant capecitabine is standard for resectable gallbladder cancers according to ESMO, which is European Society of Medical Oncology, NCCN, National Cancer Network, and BILCAP trials. So here's presenting the case of a 33-year-old male who came with upper abdominal pain for 6 months and unintentional weight loss for 6 months. After carrying out a general physical examination, everything was normal. The abdominal examination showed a palpable abdominal mass, after which every other systemic examination was normal, which prompted us for doing an imaging study where MRI showed a T2-weighted hyperintense lobulated lesion with central necrosis in the gallbladder, fossa infiltrating the liver above and the colon below. A PET-CT revealed a large FDG event mass in the gallbladder fundus and the body. The initial clinical staging for this type of carcinoma in mind, we did staging laparoscopy confirmed by a locally advanced tumor involving the colon. You can see the picture here. A pre-op MRI was done and a well-defined T2-weighted hyperintense lobulated lesion is seen out here with central necrotic areas in the gallbladder fossa with infiltration into the liver and the colon. So after staging laparoscopy, we did radical cholecystectomy with right hemicolectomy due to tumor infiltration into the colon, aiming for R0 resection. And after this, the staging laparoscopy and histopathological findings following this revealed adenosquamous carcinoma with extensive squamous overgrowth showing a biphasic tumor morphology in the background of intrapolycystic papillary neoplasm, ICPN. Pathological staging shows that it was invading the hepatic parenchyma and the serosal surface of the hepatic flexion of colon and one level 13 lymph node which showed metastasis. Hence, it was pathologically staged as T3 and 1. ICPN is shown here. And this photograph shows the biphasic tumor morphology. It shows adenocarcinoma above as it is marked there and squamous cell carcinoma component below. So post-operative treatment, we started 6 months of capecitabine and oxaliplatin. Capecitabine was given according to the BILCAP trials based on the gallbladder adenocarcinoma protocols. But however, despite chemotherapy, the disease progressed with metastatic squamous cell carcinoma at the duodenocolic fistula, requiring palliative fetal jejunostomy with ileostomy and palliative chemotherapy recommendation. Patient was lost to follow-up after that. So this is a rare case, as I also mentioned. Squamous component is greater than 25% with less than 5-year survival rate of a 32-year-old male who presented with these complaints in the upper abdominal quadrant of the person. Despite treatment, there was metastasis, and hence, this tells us that early diagnosis and aggressive multimodal management are crucial. Which brings us to the discussion which I've already covered. The literature highlights the aggressive nature of the carcinoma due to the squamous component, that is very important. And the rarity emphasizes more research and studies into the project and into the topic as well. Absence of adenocarcinoma of the gallbladder specific protocols. Due to this rarity, there is no robust specific treatment guidelines, and hence we end up taking data which is currently based on adenocarcinoma. Current guidelines recommend radical cholecystectomy aiming for R0 resection as the only curative option for resectable gallbladder cancer. And the BILCAP trial supports the use of adjuvant capecitabine for 6 months in resected cases, although its efficacy specifically in adenosquamous carcinoma of the gallbladder still remains unproven. Hence, multidisciplinary and multimodal management in order to manage an adenosquamous carcinoma case of the gallbladder is important, and imaging studies such as MRI and PET-CT are essential. Multidisciplinary management with collaboration with surgical oncologists, radiologists, pathologists, and medical oncologists for comprehensive care to improve clinical outcomes and aggressive nature of the disease becomes important. Hence, concluding this case, adenosquamous carcinoma of the gallbladder is a rare malignancy, and hence, due to limited literature available, more studies into this topic is important. And importance of early detection and management. Early detection and multidisciplinary management are crucial to improve the clinical outcomes. These are my references. Thank you.
Was PET-CT then? PET scan also. PET scan.
PET-CT was done, sir.
Okay. Metastasis was there beforehand itself, before the treatment began.
I'm sorry, sir.
Metastasis was detected even before the treatment began.
Yes, the PET-CT showed FDG focus was there, sir.
Wait.
FDG focus was seen in level 13 lymph node, sir. Next to the
Only in the abdominal cavity. Any distant metastasis was
distant
there?
metastasis was not seen.
Okay. So, can you tell me the current guidelines for the management of gallbladder stones? GP stones. When to operate, when not to operate?
Current treatment guidelines for gallbladder stones, for cholecystitis, of course, gallbladder resection is there. But if the patient has comorbidities like RBD positive patients, so we don't usually go in operating with the patient and looking at gallbladder.
What is cholesterolosis?
Not aware, sir.
Okay. So, which classifications used for stomach cancer?
We have a Japanese classification for the stomach cancer.
Any surgical procedure you can think of? What is HIPEC? HIPEC. Was HIPEC given in this case?
HIPEC is not.
What is HIPEC?
I'm not aware.
What is intraperitoneal chemotherapy? Any idea?
Intraperitoneal chemotherapies are through the patients, we can transfer chemotherapy.
So, intraperitoneal, not the abdomen. In metastatic lesions, what we do is now, during surgery, we give intraperitoneal chemotherapy.